my pal for the kind invitation to take part in this symposium. So I'm just going to share my screen. Okay. Okay, that's okay? The screen's there? Yeah. Okay. So so thanks for the invitation to take part in the symposium. So that I'm going to be talking about in the Science and Smile section, and I chose basically one topic which I think is quite interesting, and I'm going to really talk about this in a lot more detail, and I think it's relevant to all of us. And this is nerve regeneration following Smile. These are my financial disclosures. So, of course, we all know small incision lenticle extraction, which is the acronym, is a small incision keyhole surgery where lenticle is basically extracted through incision, and it's probably the end point of lenticle extraction surgery. And there are lots of advantages when we see these basically smaller surface wounds. Theoretically, certainly the eye can be biomechanically stronger. There's this issue of any sort of rupture to the flap in patients doing sports or sports-related activities in which there's a chance of getting injuries. And of course, one of the big advantages is they should provide you with a better ocular surface because there should be less issue with dry eyes. And these are patients on our RCT on the right-hand side. You'll see a typical LASIK flap on the left-hand side. The patient basically in the left eye had Smile. And typically when you see these eyes at 1 month, you'll see typical punctate inferior epitheliopathy staining on the LASIK eye, and you don't really see that with the Smile eyes itself. You get a slight reduction in a tear breakup, but you see a generally better ocular surface. So it tells you that the ocular surface is slightly better with the Smile procedure compared to what we see in LASIK. Now, about 6 years ago, we looked at this in detail in an animal study, and what we're able to show is that over an 8-week period, when you compare the nerve regeneration in LASIK, you can see in the top compared to Smile at the bottom, you had a faster regeneration of your nerves in the Smile eyes compared to what we saw basically on the LASIK eyes. And these were matched for the same refractive error. One eye of the rabbit had Smile done, one eye of the rabbit had LASIK done. So what we basically noticed was that at 1 week, you had a reduction in subbasal nerve plexus in both groups, but you had faster nerve recovery in the Smile eye compared to what we were basically seeing in the LASIK eyes. The other thing that we also noted on in vivo confocal microscopy is that the morphology of the nerves was very different between the two groups as well. With LASIK, typically we saw more sprouting nerves like you can see over here, which is indicative of nerve regeneration. And this is one of the thinkings that gives you the hypersensitivity sometimes you can see basically with LASIK patients. But with the Smile group, what we noticed was they're much more longer nerves of normal basically nerve morphology. So basically the nerves that regenerated seem to be morphologically much more normal. Subsequently to our paper, there was a whole gamut of basically papers published from clinical literature from 2014 up to about 2015, 2016. And if you look at the results from this, when you're comparing Smile to LASIK, you'll see most of these studies basically showed an improvement in outcomes, whether you're looking at Cauchy-Bonnet, OSDI, Schirmer's tear breakup time, or even in vivo confocal microscopy in favor of the Smile eyes compared to those of basically the LASIK eyes. So it showed basically what we saw in the animals was basically what we were seeing in the patients as well. Now, if you look at the nerve regeneration following refractive surgery, you will see that basically, typically with PRK and LASIK, of course, you have this immediate denervation at 1 month, but over sort of like 1 year and then basically 5 years, you'll see an improvement in the innervation on this side. Now, typically in Smile, you can see over here in the green bar over here, you get less denervation in that first month period. But most of the literature is really focused on just the 6 months. So often people ask me, well, what's happening basically after the year in the Smile eye? Does it make a difference that you haven't got so much denervation in the first month if basically by 1 year, the LASIK eyes are basically catching up? And does this early denervation make a difference in the long term? I mean, are you going to basically still have this advantage at 5 years? Or do we just tell our LASIK patients, okay, the Smile eyes are basically going to be better at 6 months or a year, but basically by 1 year, you guys should basically be equal in both sides. And this is what we basically aim to investigate and study with this study that I'm going to basically be talking about. So recently we published a randomized controlled trial. This was a study that's published in ophthalmology, looking at 70 patients with RCT with 1 month follow-up. They were very specifically randomized with specific spherical equivalent refractive error in basically both outcomes. And you can see the outcomes of the LASIK eyes on the left and basically the Smile eyes on the right-hand side. So there was no statistical difference in basically the outcomes. I mean, the study was powered to look at refractive error, but interestingly, what we noted is that over the year, the Smile eyes changed less than basically the LASIK eyes with respect to spherical equivalence. But this gave us an invaluable data set of patients that we could basically look to for other basically studies. So what we did is that the randomized control study started in 2012 to 2016. These are the parameters that basically we stuck with back in when we were doing this in 2013. We used femtosecond laser flaps of 120 depth. Smile caps were basically kept at 180, and the incision size were basically 2.8. So this is not what I do on my current smile, but that's what we were doing basically back in 2013. So what we did was we brought these patients back for follow-up. So typically they were split into two groups. The mean follow-up was 4.1 years. The group one basically had an average follow-up of 2.7 years. And most of these cases were done between 2014 and 2016. And group two, with a slightly older cohort, they were done between 2014 and 2012. And they basically had an average of 5.5 years follow-up. So we basically got these patients back. They underwent in vivo confocal microscopy, examining the central, superior, inferior, temporal, nasal quadrants. We then basically imaged them in detail. We used software, which I'll talk about a little bit over the next couple of slides, to basically analyze the nerve regeneration. We also compared them to 6 age-max normal subjects to see whether the nerve regeneration went back to normal. And as you know from in vivo confocal microscopy, remember, you're only looking at a 400 micron square view when you're imaging basically the nerve as well. The patients also underwent clinical assessment. This was done with Schirmer's type 1, Oxford scoring, fluorescein CFS staining, sensitivity with Cochet-Bonnet, NIBUT, and ocular surface disease OSDI questionnaire. So the first thing was how we were going to basically analyze these nerves. So what we did is that we tried to validate some software that is available online. One is basically called CC Metrics. And what you can see on the left-hand side in A is typically a picture of an in vivo confocal microscopy of basically a nerve plexus or nerves in the stroma. Now, if you look at B, what you'll see is that you'll see a manual mode of the CCM Matrix software where you could basically have to manually track basically the main nerve branches, which are in red, and the branches basically in blue. And where you see a trunk branch coming off the main branch, green dots. So this has been done by basically hand. On the right-hand side over here, you'll see in C, which is done basically with ACM, which is an automated software from the same basically company as well that developed the manual software. And this is all done basically by a computerized system. But you can see that sometimes with the automated software, where you can see these arrows are, you sometimes miss a few of the nerves on this side over here. So we wanted to basically find out how accurate this software was before we started testing this on our cohort. So we took 1,700 images from 20 patients, and the information that you typically get from the basically CCM matrix is basically 3 parameters. One is CNF5FD, which is the corneal nerve fiber density. One is corneal nerve fiber length. And the third thing is corneal nerve branch density. And this will either be the main fibers branch density or basically be the total amount. So what we can basically see from this data was when you compare the ACM metrics, which is the automated system, versus 2 observers who basically were doing the manual system itself, you'll see that generally ACM metrics for all these 3 parameters generally underestimate compared to basically what the observers were getting. So you can see examples over here. This is mean and standard deviation between the 2 observers. When you look at the intraclass coefficient and you look at the variation, you can see that actually it was a lot more accurate basically for the nerve fiber length as well as nerve fiber density. And these results were much less accurate basically for the branching density. So you're good at basically distinguishing nerve fiber lengths themselves and density, but there was variation between the 2 observers as well. And also comparison, when you compare to the automated system, there was also a significant difference as well. But these scores are not so bad, about 0.78 and 0.8 basically quite good coefficients with respect to accuracy. When you look at basically comparing the observers, at the top, you'll see intra-observers. So the mean bias of the intra-observers was actually quite low, as you'd expect. And this is shown in the equivalent Bland-Altman plots on the right-hand side. And when you look below over here, the inter-bias was basically much larger. So what this tells you is that if you're going to get different people analyzing the software data, you're going to get a larger variation in basically your outcome. So ideally, when you're doing the patients, you want one person to basically do all the analysis if you're going to basically do it by hand and not basically use your automated system. When we compared the manual to basically automated system, you can see on the right-hand side, when you look at the correlation function over here, the solid line is the line of best fit. The dotted line over here is the line of equivalence. What you can see is that generally the ACM matrix, the automated system, generally tended to basically correct compared to what we were seeing in the manual. When there were less fibers, this was less of an issue. But as the fiber density got basically more, you can see that the automated system generally tended to underrepresent compared to what we were basically finding in the manual system. So what that shows you is that you cannot switch between manual grading and automated grading. And there were some deficiencies in the automated grading system that we had to basically be aware of. So we go back to the study. So what we did was because we did this pilot study, we knew that we had to only use 1 observer. These are the 4 parameters that basically you get from the manual basically programming. And we also wanted to look at sprouting nerves per frame and also beating nerves per frame. So this was done by one of the medical students that was attached to us during the COVID time. So she spent a long time basically looking at these images. Using the automated software, you get those 4, plus you get additional 4 data. You get branch density, you get fiber width, you get fiber area, and also you get fractal dimensions. And if you have a high level of fractal dimensions, you mean you have a higher basically nerve morphology. And these are some of the examples of our patients in the 2 groups. This is basically LASIK at the top, SMILE in between, the control group in E, and some sprouting basically coming off the corneal nerves over here that typically we saw in both the refractive surgical groups that we didn't basically see in the normative control groups. So what do we find? So what we found is that when you actually look at clinical parameters based objectively and also subjectively, there was no significant difference clinically when you assess these patients with respect to clinical assessment of the ocular surface in the SMILE or the LASIK group. And this is basically at 4.1 years basically follow-up. However, when you start looking at the in vivo confocal microscopy, you can see over here in dark images, the ones that are basically clinically significant. The post-LASIK eyes has significantly less corneal nerve fiber density, corneal nerve fiber layers, branching density, and total basically branching depth at a mean basically follow-up of 4.1 years. The other thing that we basically noticed is that the SMILE group had significantly less beading. And what beading means around the nerves is the beading is a response to nerve damage where you get a focal basically enlargement of the axons itself. And it's much more common where you have greater areas of basically subbasal nerve plexus. And we saw more of this in the LASIK eyes compared to what we saw in the SMILE eyes. When you break it down by groups, so remember the first group of group 1 is 2.7 years compared to 5.5 years, and you compare the groups, you'll see an improvement in the nerve fiber density, the branching density and fiber length between the 2 groups, between 2.7 years and 5.5 years. So what this means is that even up to 5 years out, you're still getting significant nerve regeneration in your SMILE group compared to what you're seeing in basically 2.7 years as well. However, when you compare to age-matched controls, these values were still significantly lower, even at 5.5 years. When you look in the LASIK group, again, we saw a similar trial where you basically get an improvement where you compare from group 1 basically to group 2 from going from 2.7 years up to basically 5.5 years. And likewise, you still have a more sprouting nerves even at 5.5 years post basically refractive surgery, showing you still getting active regeneration. And again, these are significantly different and significantly lower than what you see in basically age-matched controls. So what about when you compare the 2 procedures? So when you compare the 2 procedures, what you see at 6 months, you also see at 2.7 years, which is basically that SMILE has significant better nerve fiber density, branching density, fiber length, and total basically branch density as well, compared to what you're basically seeing in the LASIK group. But when you see these at basically 5.5 years, you'll see these parameters and these numbers are getting much, much closer, but SMILE still has an advantage at basically 5.5 years in nerve fiber density and also basically in branching density. And the other thing that we noticed was the beading is significantly less in SMILE compared to LASIK. So what it means is that the nerves are regenerating are much more normal in the SMILE group compared to what we're basically seeing in the LASIK group. Now you can see from this chart here, this shows every single case itself. Because it's contralateral eye study, you can basically do a curve like this. You can see all these results above basically favor SMILE, the ones below basically favor LASIK. And interestingly, most of the groups you'll see in basically group 1 are in favor of SMILE. You have the odd one basically below over here that basically favor the LASIK. And these 2 ones over here are interesting because these ones, when we looked into detail, are basically patients from the low myopia group where you expect your nerve regeneration to be faster. And lo and behold, it's actually a little bit faster in the LASIK group compared to what we saw in the SMILE group. So LASIK patients that had better nerve fiber density, branch density, and fiber length were all in the low myope group. The average was about 2.5 diopter correction. So what about in correlation to spherical equivalent? So when you compare the results of nerve fiber density to spherical equivalent, what you can see in the high myopia group, you have significantly lower nerve fiber density in moderate to higher degrees of myopia compared to the lower myopia group. So that's a greater than -6 compared to less than basically -6. And the nerve fiber density was 9.3 versus 14.8. But this difference we did not see in the SMILE group. So if you look at basically figure A over here, you see the line is absolutely flat, while the beta over in the LASIK group over here, -10 is on this side, -2 is on this side itself. So you have a much lower nerve fiber density in the high myopic group compared to the lower myopic group. Again, basically showing the advantages with respect to nerve density of lenticular extraction versus basically a LASIK procedure. So in conclusion, published clinical studies have shown advantage in nerve regeneration in SMILE compared to LASIK only in the short term. Most of the studies only have follow-up to 6 months. This cross-sectional study in a refraction match population showed that there was no significant difference in clinical parameters between SMILE and LASIK with respect to Schirmer's, corneal sensitivity, Oxford staining score, and IBUT at a mean time of 4.1 years. However, on IVCM, you can see there's significantly less corneal nerve fiber density, branching density, fiber length, and total branch density in the LASIK group compared to the SMILE eye. So the LASIK group still don't even catch up, even basically by 4.1 years. And also you have significantly more beading in the LASIK group than in the SMILE years. Even at 5.5 years follow-up, the SMILE patients had better basically in vivo confocal microscopy images with respect to nerve density compared to the LASIK in the majority of the eyes. The only group that was even close were those basically of low myopic patients, which basically showed slight improvement in LASIK basically over SMILE, but these were basically much more comparative, but they were still basically less than our age-matched controls. Thank you for your attention.
Thank you.